Hello, my name is Jeff Hauk, and I'd like to acknowledge my co-authors Dan King, Tyler Cuttaford, and Sarah Racola. The title of this talk is Characterizing Patients' Acceptable Symptom State at Short-Term Follow-Up of a Collaborative Primary Care PT-MD Service. So we all know that when you implement a primary care musculoskeletal service, that patients present with a wide range of problems. And many of the problems patients have multiple regions or joints affected, making it difficult to apply disease-specific questionnaires or patient-reported outcomes in this environment. So generic are preferred for disease-specific. We also want outcome measures that have low patient burden, are easy for providers to interpret, and because of the different conditions, musculoskeletal conditions, affect different health domains like physical function, pain, and self-efficacy differently, a multidimensional assessment is preferred. So the patient-reported outcome information system, or PROMIS, and a different scale like global rating of normal function are options for assessment of these patient group. We know currently that PROMIS measures, when we pit them against disease-specific measures, that they perform equally as well in terms of psychometric properties and in terms of spine problems, foot and ankle problems, and shoulder problems. We also know that by using computer adaptive technology, the patient-reported outcome information system scales, or the PROMIS scales, take less than a minute to complete and are much shorter than the current disease-specific scales. And because they include many different items in the computer adaptive algorithms, that they have fewer floor and ceiling effects. So by incorporating the PROMIS scales, it gives us a chance to capture specific health domains and achieve this kind of idea of a multidimensional assessment. Now, in contrast to capturing health domains, we could also ask a global rating of normal function, which asks patients to rank their joint or body region relative to what they would expect normal to be. The interpretation of the PROMIS scales is relative to the U.S. population. So in the 2010 census, the PROMIS scales were normed to the U.S. population, so therefore 50 is the US average of the U.S. population, and 10 points is one standard deviation. And PROMIS scales always measure the attribute, so a higher score is more of the attribute. So if it's a negative attribute like fatigue or pain, then more means that they have more symptoms. And so we can see in the heat map here that a higher score for symptoms would indicate red or yellow or more problems. In contrast, a scale like function, more of the attribute would mean a better score. And so we can see here that a lower score gives us the yellow or orange range of this heat map. Now, what we don't know is how to interpret these scales outside of the normal population. So, for example, what's a benchmark for reaching kind of a normal symptom or activity level? So the patient acceptable symptom state is a dichotomous question that was evolved to do just that, to judge when patients have reached kind of a normal level or an acceptable level of pain and functional impairment, and the reference is satisfactory. So patients are asked to respond yes or no whether their current level of pain and functional impairment is satisfactory to them. Previous data has shown that on other scales besides PROMIS, that the pass point, okay, where people become pass yes, is near the average of the norm for that scale or slightly below. So the initial hypothesis would be that for the PROMIS scales and for the GRNF scale, that it would be somewhere near the norm for that particular scale. So the goal of this, or the purpose of this research, was to determine whether selected patient-reported outcomes discriminate and predict a patient-acceptable symptom state at short-term follow-up after a collaborative PT primary care service, with the goal being to improve interpretation of the scales for providers. Essentially, knowing this benchmark would allow providers to set functional goals for patients and think about discharge planning or whether care needed to be continued or stopped because of it reaching this kind of past state. So the scales we assessed were PROMIS physical function, pain interference, and self-efficacy of symptom management, and then the other scale, the global rating of normal function. The sample included 22% of patients collected over a 3-month period, an average of 14 days after their primary care visit, and 94% of the calls were in less than 30 days. This yielded an approximately even number of past yes and past no patients that were at a little over 60 years old, were predominantly female, and were at a body mass index just over 30. The questions were queried 1 to 7 days following their service date over the phone, and the questions asked were the patient acceptable symptom state, global rating of normal function, and the PROMIS pain interference CAT, physical function CAT, and the self-efficacy of symptom management CAT, so all the computer adaptive algorithms. The analysis focused on 3 different things. The first was, are patients discriminated at the level of past yes compared to past no? So were PROMIS scales different for the aggregate scores of past yes patients compared to past no? A two-way ANOVA was used to evaluate this. And also for the global rating of normal function, were aggregate scores for past yes versus past no individuals different? The second goal was, or purpose was, to predict a past yes or no state in individuals. So receiver operator curve analysis was performed. We used area under the curve, where a 0.7 area under the curve was considered reasonably accurate or good but not great. And then we looked at 2 different thresholds, with the idea being if we set our thresholds with a sensitivity and specificity of 95%, we'd end up with a higher accuracy but lower proportion of patients classified. If we used an 80% sensitivity and specificity threshold, the idea was we would have a lower accuracy but a higher proportion of patients classified. And so that was our hypothesis. And then lastly, we looked at a logistic regression analysis to see the effects of combining demographic variables like age, gender, BMI, and the days of follow-up with various PROMIS scales and GRNF to predict past state. So here's our results. So the first purpose was to compare past yes and past no individuals. And here's the ANOVA results with the t-scores here plotted on the y. And so we can see here that essentially there was a significant difference between the past yes and no people on all 3 health domains, suggesting that there's some ability for the PROMIS scales to differentiate people who were past yes versus past no. And the global rating of normal function was average of a 7 for past yes and 5 for past no, meaning the global rating also differentiated past yes from past no individuals at the aggregate or average level. In terms of predicting individual patients, here's where we did our ROC analysis. And so here we have the PROMIS scales, and this is the sensitivities plotted on the y and 1 minus specificity on the x. We can see that the area under the curve is good but not great, that moderate level above 0.7. And here's the 3 scales. And so when we looked at this 95% sensitivity cutoff threshold and the 95% specificity threshold, we were able to kind of characterize, what those thresholds would be. And so for past yes, for a person to be past yes, the physical function, self-efficacy, and pain interference were all very close to the U.S. average on those scales. For past no threshold, the level of disability in terms of physical function, self-efficacy, and pain interference were all fairly significant, approximating nearly 2 standard deviations, 1 to 2 standard deviations in each case. However, the number of people classified at this higher level of accuracy for sensitivity and specificity was only 26 to 40.4%. However, the accuracy achieved was still kind of moderate, with 75 to 80% accuracy. So when we change the thresholds to using 80 and 80% sensitivity and specificity level, the picture changed slightly, where the past yes patients now were determined by scores slightly lower than the average for the U.S. population for physical function and self-efficacy, and slightly higher pain levels for pain interference. And similarly, for the past no categorization, the severity of those scales was slightly less. There's a big advantage, though, in terms of the percent of patients classified. So here we were able to successfully classify, nearly 3/4 of the patients for each scale, and with very little loss of accuracy. So the accuracy was less than 10% lower for each of these PROMIS scales. So likely the more practical approach in terms of using these scales to classify people or understand when they're reaching past yes and past no levels would be to go with the 80% threshold. We turn to the global rating of normal function, the same process in terms of the ROC analysis, and we can see here that the OC is the same, a good but not great level. And if we apply the 95% sensitivity and 95% specificity thresholds, you can see here is for past yes, an 8 or above was a past yes. For past no, it was 3 or below. And this successfully classified 42% of the patients at an 80% accuracy. If we change the thresholds to 80% sensitivity and 80% specificity, what we can see is that the past yes now is a 7 or above, and past no is 4 or below. And this improved the classification to 72.3% of individuals at a 70% accuracy level. And then the final analysis had to do with logistic regression, where we were looking at combining all the demographic factors and the PROMIS scales and GRNF scales themselves, see which ones best predicted the 80% threshold level at an 80% thresholds. So we use the next analysis, logistic regression analysis. And what we did is we used the categorization at the 80% threshold level to see if combining the PROMIS scores and demographic variables achieved some level of accuracy for the pass yes or pass no status. And essentially the PROMIS PF, self-efficacy, and age were retained in the model, and all the other variables were not. And this gave us this kind of accuracy chart where all of the patients were classified at essentially a 73.4% accuracy level. So what this suggests is that the combination of PROMIS PF and self-efficacy at the 80% thresholds are really the best way to kind of predict who will be a pass yes or pass no individual. So in summary, this analysis agrees with previous studies that suggest that normative values on these PROMIS scales represent something close to a pass yes state, or slightly below if we are able to accept just a minor decrease in accuracy. So there's two take-home messages. One is that, yes, the PROMIS scales in terms of physical function, self-efficacy, and pain all relate to the judgment, a patient's judgment of whether they're pass yes or no. However, those scales alone at best only achieve a 70% accuracy when combined, and in particular the physical function and self-efficacy scales combined to make that prediction. And the reason that pain interference may have dropped out of the logistic regression model is because it's highly correlated to physical function. And so it's possible that those could be interplayed. The global rating of normal function, it's unclear what the normal values are, but this data suggests that probably an 8 to 10 or 7 to 10 score means that patient is accurately placed in a pass yes category at a 70 to 80% level. And patients who are 4 or less are at the same level of accuracy in determining their categorization. So this scale is also useful, even though it doesn't kind of capture exact health domains. It's simpler to use and just basically gets kind of a gross measure of a patient's judgment of how their joint is relative to normal, and helps us understand that having the complete recovery in terms of being equal to the other side isn't necessary for a pass yes judgment. And then the final thing is that some of the idea of these confounding variables, such as length of follow-up or gender, also influencing pass status, wasn't really supported in this data, meaning that they could be ignored relative to pass status. So what's interesting is if other variables could also be combined with these to more accurately predict pass status. And it's probably true that some variables related to sports or patients' desires to achieve different levels of activity may influence this outcome as well. Thank you.